Hello, everyone, and welcome to the Wednesday live stream. It feels like forever because I was gone at the conference last week, which we're going to talk all about, so don't worry. But it's just weird. It's weird not being here every week. So we were all gone in Chicago last week, so that's why we weren't here for a live stream. So welcome, everyone. I hope you're having a beautiful Wednesday. I already see people commenting in the chat saying where they're from. So one of my favorite things is always to hear where you're from and who you're here to support. So let us know where you are located. I'm in Los Angeles, California, in Orange County. I always say LA because most people outside of California don't know where Orange County is, but we're like the county right between San Diego and LA. So if you're in San Diego and you're going up to LA, I'm like right there in the middle. But I was in the lovely Chicago all last week for the International OCD Foundation's 30th annual conference. I can't believe it's 30 years old, but I was in Chicago. Is anybody from Chicago? Because it was so beautiful. I had such a good time. We're at the Marriott Marquis by the water. So when we were eating and stuff, you could see like a bay. It was gorgeous. So let us know where you're from. I see that Nathan's already let us know he's from Georgia. So welcome. We have Cape Town from Gail. So that's amazing out there in South Africa. And yeah, so everybody just let us know where you're from. And then who are you here to support? Are you here to support yourself? Do you have a kid with OCD and related disorders, a partner, etc.? It's always important for me to find out. If you're new to our live streams, we're here every Wednesday at 12 Eastern. I'm a licensed therapist. I treat OCD, body dysmorphic disorder, and related disorders at the Gateway Institute in Orange County, California. I also have OCD and related disorders myself. So I am always happy to host these every Wednesday at 12 Eastern. We always have different clinicians on and answer your questions. If you are new here and you're watching, we're live on all different platforms. We're on YouTube, we're on Twitch, we're on X, we're on LinkedIn, and we're on Facebook. So whatever platform you're on, if you put in the comments your question, they'll pop up. I realize for you watching, you're only seeing the comments on the platform you're on. I see it from all different platforms. So sometimes that's why when I ask questions, people that I saw at the conference are like, you always have all these questions and I don't always see them until they come up on the screen. Now you know the magic. So, but anyways, I'd really, really appreciate if you ask any questions, any comments, and support each other in the chat. This is a family, a community. So be respectful and support everyone here. Quickly, before I announce my two lovely guests that are on the screen with me, always remember that this is a live stream. It's a platform to give education and community and resources, but we can't jump in and handle any crisis situations during this live stream. So if you are really struggling, you want to find a provider that can work with you on an individual basis at iocdf.org/find-help. You can also call 911, dial 988, go to 988lifeline.org, or go to your local emergency room, and that way they can provide support. But other than that, we're happy to have you, and we're here every Wednesday, 12 Eastern. All right, so today we're going to be talking about the International OCD Foundation conference. What were some of the highlights? What were some of the new information that came out? And what we're so happy to bring on, shout out to Liz Lindley, who works at the IOCDF, is we wanted to bring two people that had never been before and hear their experience, which is awesome. So I'm going to introduce the two that you see in front of me. I'm going to start left to right on my screen. I don't know if it's the same way for everyone else, but Dr. Sarah Amato, who said I could call her Sarah during the live stream, so that's why I'm calling her Sarah, is a clinical psychologist in the pediatric acute care program at Nationwide Hospital, Children's Hospital rather, and is faculty in the development of psychiatry at The Ohio State University. She specializes in treating youth with obsessive compulsive disorder, OCD, including those with co-occurring suicidality and other severe mental health concerns. Dr. Amato received her doctorate in psychology, a PsyD, from California Lutheran University in 2022, and received extensive clinical training in CBT for OCD, as well as DBT throughout her education. She is passionate about working with families struggling with OCD and hopes to increase access to evidence-based resources and diminish barriers to effective care. Well, welcome, Sarah.
Thank you.
Happy to have you. And now my other guest is Dr. Lovely Binion, who said I could call her Lovely, which is such a cute name. My name is Chris. I always say my parents gave up. My sister is Gabriella and Selena, so they got the pretty names. But she is an ED.D and an LPC. She, her are her pronouns, and she is a staff therapist. She is a licensed professional clinical counselor and strives to connect with individuals to assist them in improving the well-being of their lives. She has a master's in clinical mental health counseling and a doctorate in education. She is passionate about understanding culture and diversity, strengthening behaviors, and enhancing mental stability in all the people she works with. She believes in protecting children, strengthening families, and building futures for those who have experienced trauma. She encourages clients to know that they are safe and non-judgmental space where they can receive the support and therapeutic insight that they are seeking. She prides herself in being dedicated and compassionate counselor with 15 years of professional experience counseling individuals and groups. She is strong suited in person-centered therapy, cognitive behavioral therapy, and mindfulness therapy using a variety of techniques and interventions to meet the client's needs. Welcome, welcome. Lovely. It's so good to see you.
Thank you. It's good to be here.
It's good to see you too. So they always have these. Well, first of all, I just want to say to the people watching, so many people came up to me at the conference and said that they watch the live streams either live every week, or we always get thousands of replays and on our YouTube and Facebook channels. And so many people came up to me and said they watch it every Wednesday or they watch the recordings back. And I just want to say thank you so much. It was so amazing to meet all of you in person. And I was just honored to connect with so many of you that watch this. So just want to say that to everybody that's watching. But so good to hear from you two, because what I would like to find out, I've been at these conferences for a long time. They give you like a badge. And I had the one that said like 15 plus conferences, because I went way back when I was still suffering. And so I went at the conferences when I needed my own help. And now I've come back, obviously, as an advocate first. And then when I became a licensed clinician, I came back as a professional. So I've been there the whole time. It's like a reunion, but both of you, it was your first time. So I'll throw it out to whoever wants to take it first. What were like those initial, you're getting your badge, you're walking through the door. What were some of your initial like thoughts and feelings experiencing the community?
My first reaction was that this is huge. There's so many people here, and it like immediately was already really well set up, and just getting my badge at that big long table where you see everybody just waiting to greet you, and everyone was so friendly. The conference is something that I've been wanting to go to for a while, but various barriers kept coming up, and so I was really, really just happy to be there. And then having my energy met by other folks who were just happy to see me was really, really cool. It was automatically super welcoming.
Thanks, Sarah. How about for you, Lovely? What were some of those first feelings or emotions that you had when you first walked in?
I agree. Like Sarah, I walked in and was like, this is huge. I am from Chicago. But I've never been in that building, and since they've done the new development and everything. And I was anxious, I was nervous, I was, all of the feelings, trying to figure it out, but mostly excited. I also recognized that it was well organized, everybody was super friendly, and just everything just seemed to be well oiled in the way to which you can just navigate it without having too many hiccups like myself, as I coin myself to be directionally challenged.
I love Chicago. So you all have a huge Greek population. I'm Greek, my mom on my mom's side. So we had to get Greek food in the Greek community. And then there was the Bay, and it was beautiful. How exciting was it to be in your hometown?
It was great, but I have to hear how much you enjoyed the Greek food. Being the culture, you have to let me know if you enjoyed it.
Oh, I love it, because here's the thing. My family, one of my family down in San Diego owns a Greek restaurant, and then my mom and my aunts can throw down in the kitchen. So I'm always nervous going to a Greek restaurant, because I'm like, oh, please don't be bad. It was so good. But I love the culture. We walked around. It was beautiful. The food was amazing. It was like, yeah, I just love it. And I'm sad because out here in LA, we don't really have a Greek spot. So I was so excited to see it. So y'all are doing my people well out there.
Wonderful, wonderful. I'm glad to hear that. But yes, I found out about the conference and I was going to attend. And then I was even more excited and happy when I found out that it was in Chicago in my own backyard. So of course, having that accessibility was just awesome. And then being a first timer and being able to go and really just being, amazed by every single thing that I experienced, it just really drew me into the conference. And from now on, I'm dedicated and I will be there regardless of what city it's in.
Yay! Well, we're gonna be in Seattle next year, so
I'll
that's
be, I
exciting.
know I'll be there.
That's
I
my
love it.
hometown.
Oh,
Oh,
that's your hometown.
awesome.
Yeah.
We're going
Yeah.
from- Yeah, no, it's lovely because you always have to fly out. But when it was in LA in 2014, it was like the first conference where I could like drive there and back instead of like flying at a hotel. That's amazing. Yeah, as you said, there was a lot of people. We ended up having over 2,200 people in person, so 2,200 people, and then we had another over 1,000 watching virtually through the platform for being able for people to see it at the comfort of their own home from hybrid. What the question I'll throw out to both of you is like, tell me a little bit about just what you noticed with the people, whether it was clinicians or families or kids or people with OCD walking around. Like, what was that experience like? What did you kind of witness with the community?
The community was just so engaged. I thought it was just brilliant to have family and friends and people who are living with OCD and anxiety and other related disorders. It is super helpful for them to be able to get these resources, as well as us as clinicians be able to engage and understand these lived experiences even further beyond our scope of practice, beyond the research that we read, and even beyond some of our clients that we engage with on a weekly basis. Everybody is different. Everybody has their own individual experience. So to be able to be in the same room with those individuals, it was just took my breath away. And then of course I love the kiddos. So that was an extra bonus for me.
I always know the kids are around because I'll hear like if you are watching and you haven't been to one of the OCD conferences, one of the really cool things is I think that kids in their real lives don't get to really interact with other kids going through the same thing. That's what's so important about these live streams, the IOCDF in general, and the communities that we're trying to build. But they're always loud and I love it because the kids are coming, they're like superheroes, they're running around the rooms, they're playing games, they're laughing. I always love that. Same question for you, Sarah.
Yeah, so I think one thing that I was particularly struck by was just being so impressed by families of folks experiencing OCD and the parents that show up for their kids and with their kids, and parents who are joining the educational sessions just trying to learn as much as they can in order to support their child who has OCD or a related disorder, and just being so like touched by the families working so hard to be a solid support and wanting to do it the right way. That was really, really cool to see. And again, just everybody was so friendly and kind to each other. And you just had the mix of people with lived experience, clinicians, researchers, everybody in one room together and being able to ask questions and have discussion. It just leads to a really nice and wholesome understanding of what other folks are going through and our advances in the field and where we still have some barriers. It's just the kind of wholeness of it was really cool.
Yeah, I've gone to a lot of different conferences, obviously, over the years, and I love getting my CEs in person because I just like vibing with people. I can't be behind a screen all the time.
Yeah.
But I think that's what makes the IOCDF conference unique is you have children, you have families, you have researchers, you have clinicians, you have educators, you have people in the community that just want to learn. A lot of conferences aren't like that. So I think it's so cool to see, like, what I always like to see is like the presenters will speak and then afterwards like people get to ask them questions because I went to a conference. It wasn't for mental health, it was for something else, but it was like after each person presented they like went out the back and I was like, okay, come on now. Like nobody's Ariana Grande, like nobody's Denzel Washington, nobody's Taylor Swift, like we don't need to be like hiding in curtains. But that's just cool. Was there any sessions that stuck out to you or poster sessions or things that you heard from clinicians? Was there something that was just kind of eye-opening for you? Because you both work with people with anxiety, depression, and OCD, and all those things are being discussed. So was there any talks or people or just anything that you're kind of like, oh my God, that was new or interesting or just reinforced something that's important?
Yeah, a couple stood out to me. One, I always like a solid panel Q&A. So there was the pediatrics expert panel Q&A, and Dr. John Passantini, who I trained under, was a part of it. And then all these other huge researchers in OCD just asking or answering questions posed by the whole group. And that one was really cool. And just, I always like getting information from the experts. And then also I attended the neuromodulation and neurosurgery session, which I wasn't sure how I was going to feel about, but it was just so much great information about new research and new technological advancements for those kind of treatment refractory OCD subtypes and people who are struggling more. And there was a man with lived experience who shared about his experience getting surgery. And it was just a really informative and cool session.
That's awesome. For me, what drew me was coming in, learning more about PANDAS, which I have a client who is suffering that. And before having this client, it was a new version of OCD that I hadn't worked with. And it was just really exciting and affirming to hear some of the practice that I'm already instilling, that, these renowned clinicians are utilizing, and also getting different information that I can immediately bring back into my practice and to work with my client, as well as going to the new emerging tools with ERP and OCD. I love ERP. I'm a huge fan of it. And I was amazed to see, them doing, as you named, Chris, the superheroes with the kids. I thought I made that up. I use it in my therapy all the time. Yes. So it's so affirming and so validating to hear these terms, to hear these anecdotes and these tools and interventions that we're utilizing, and being like, oh, other folks are using the same language. I didn't make this up. We all have like minds, even though we aren't in the same room. So that was just super, super cool, and a little kick that I give myself out of.
I know, it's so funny because I both hate and love it. Like, I love it because it's like validating as a clinician. You're like, okay, other people are doing this too, and it's working. But I always hate it. I think I'm so creative, and I'm like, oh, I have this thing, and then you go to the conference and somebody else does it, and you're like, because I did a talk on like being a I was going to the conferences since I was young, and I started the young adult track at the conference, and we did a talk once about like being your own superhero, and we did this whole thing. And I thought I was like so creative. And then somebody's like, oh yeah, I love that idea. It's from this one book. And I'm like, I thought it was me. But and what I love, and the next question I want to ask you, real quick, what I really liked, and then I have a question for both of you. I really liked the plenary. It was talking a lot about like using how is ChatGPT and AI and like VR and stuff going to be the future of treatment. Because for me, I'm like, I'm nerve-wracked because some of my clients are using it for good, but sometimes like going on that ChatGPT spiral can be dangerous. And so I think it was interesting to discuss and hear both sides and really find that out. There was a really good poster in the poster session where at USC, I believe, they were taking and doing a module for upcoming psychiatry residents on OCD and seeing if that improved their understanding and ability to recognize and diagnose it when they go out and become psychiatrists or work in the medical field. So it's really interesting to do that. And then I think I was on a panel, so I already kind of knew it, but just seeing Dr. Caitlin Pinciotti speak about the way that she did a big research study on the way that OCD impacts people in the LGBTQ community. And it always just kind of reminds us that marginalized groups are impacted by OCD in unique and challenging ways. There's also not a lot of research. And I think what's really cool is when I was in grad school, my grad school program was very big on diversity and, just making sure you treat the client as an individual person. But then when I came into OCD training, there was none of that at start. But it's good to see that evolving, and it was good to see the research out there. So I encourage people, if you ever can go, that it's whether you're a clinician or not, it's mind-blowing. My mom's a registered dietitian and did a talk about the mind-gut connection, and she talked about, food and health, but then she ended up finding a couple other presenters talking about diet. And so it's just cool to see kind of like the cutting edge and what's next and what's new. So it's awesome. What I wanted to ask both of you is, both of you are obviously clinicians. For clinicians watching this who maybe haven't gone to a conference, like, why is it important as we're gathering new information? Both of you talked about stuff that's going to help you in your own practice. Why is it important to come to conferences like this and learn and keep up with the latest trends in whatever modality and challenge that we're treating with our clients?
Well, as you named, the onus is on us to keep up with the latest trends and know the changes in the different modalities and be a part of those conversations, right? Because we are the people who are leading um, the sessions with these interventions and these tools that are best practice and are the gold standard for these specific disorders. So going to these conferences definitely allows us to have that continuing education piece where we are getting the latest emerging information that's coming down the pipeline. We're able to talk to some of these investigative researchers who are people that are not only researching these things, but also making publications on these advancements. So it is, for me, it's more than just getting the continuing education. It's about continuing to sharpen my tools, in addition to being abreast to all of the latest information that is there so that I can be the best clinician for my client base.
Well said. Over you, Sarah.
I would absolutely agree. Obviously, ERP, for example, has been around for a really long time, but even in the last decade, the reasons that we know ERP to work have shifted. And if you're not up to date on the research behind ERP, the shift from, say, like habituation to inhibitory learning, to get all like technical with it, that's important to know. You have to know how to best implement ERP. You have to know about ICBT and why it may or may not work with certain folks. You need to know how to adapt ERP to neurodevelopmental folks. So just staying on top of the research and the literature is important. And for me, hearing about it in as quickly as it's coming out is important to me. One of the sessions was on genetic research in OCD. And like you mentioned, we don't have a lot of info on that. And so being able to learn about the studies that are happening right now and knowing that we might have some data next year on genetic, findings on OCD, that's really important. And so to be able to get that from the folks who are really involved with IOCDF, from the experts, is just really powerful. And it is our duty, like Lovely said, to be up to date on that.
Mm-hmm.
I hope the people watching are recognizing, because I think they don't always understand, like the public doesn't understand that we keep getting educated. And so, I was telling people sometimes ask your clinician, like, hey, when's the last conference you've gone to? Or, when you're looking for a therapist, you can ask these questions, definitely vet. I want to ask you both a personal question. What brought you into this field? What made you really excited about it? And what keeps you happy kind of just working with the folks that you work with on a daily basis? I'll start with you, Lovely, and then you, Sarah.
Okay. What brought me into this field is I started my career working in education, being a teacher, recognizing that there's a lot of trauma that our kiddos deal with before they even come into the classroom that impacts their learning. And since then, I always had a love for psychology. That was my major in undergrad. My bachelor's degree is in psychology. So when I pursued my master's, that was the direction that I wanted to go. But I also wanted to blend education and mental health because of working in education and recognizing the need that is there, and that school counselors don't all have the capacity to be able to specifically treat, mental health disorders, as well as the trauma that comes along with some of these core disorders that we have. So that initially brought me into this space, and I enjoy what I do. I love what I do. I get refreshed with new information like I received at the conference this past weekend, and I enjoy seeing the work come to fruition. And with ERP, you see that a little bit more than you do with some of our other modalities. But being able to be a part of that process and be there for the journey is just, it just warms my heart.
Yeah. How for you, Sarah?
So I guess psychology broadly, after my undergraduate degree, I worked at a residential facility for youth in the foster care system for a couple of years, and just always knew that I wanted to work with kids. And then working in residential treatment, learned that I could do it. So I got into grad school and trained, or I guess adapted my training to work with kids specifically. And in that process, completed a practicum at UCLA for their OCD IOP, working with kids, and fell in love with ERP. And I've always liked behavioral treatment, and this just took it to a whole new level. And I didn't know a ton about OCD prior to initiating my training. And when you're doing an IOP, you learn a heck of a lot about it. And I just loved it. It's a treatment that I love. I see it work. It is really interesting. It can be really fun, difficult, but fun. And so I just kept up with it. And so now at Nationwide Children's Hospital, I still work with kids, and I work with that more severe mental health concern end of the spectrum. And so I work with a lot of kids with severe OCD, and it's just a really cool population to work with. I love the kids that I work with. I love doing this treatment. It's really great.
Yeah, I think one of the cool things is I ran some stuff and did some talks, but it was cool to hear people that were like challenging themselves just by coming to the conference or just being at the conference. And I think that that's something that I remember my first conference. I was in a horrible place. I just started OCD treatment. I think I was like 2 months in, and the conference just happened to be in San Diego at the time, and I was real young. I was just learning about OCD, but we wanted to go. We had family down there. We're like, we're going to do this. And I went my first day, and I got triggered by something. I somebody said nothing bad. I mean, they were just talking, one of the presenters, but they said like a trigger word for me. And I got all in my head, and I was like creating all these scenarios and stuff. And unfortunately, we had to leave early. But you know, in retrospect, I'm proud I went, but it was so cool just to hear from folks that like this was the first hotel they've stayed into in years because of OCD, or people saying like, look, I didn't want to come down and do these activities, but like I you know, kind of got myself together and went down. So I think that was so cool to see. Did y'all get to make it? I know there's so much going on, but did you get to make it to the keynote at all, or the Saturday night party? That's why I go. Just kidding. Free food, I'm there. What was that? Well, let's start with the keynote, and then we'll talk about the party. What was it like just to see the keynote? For those of you that didn't go, we had an author who has OCD. She writes children's books, and she talked about her own experience. And we also gave away awards. Shout out to Dr. Goodwine, is a good friend of mine. She got an award. Shout out to all the people, like the researchers that got grants to do great work. So what was that like? I'll start with you, Lovely. What was the keynote like for you?
It was amazing. It was great to hear both speakers. Dr. Goodwine is a good friend of mine as well, so seeing her and celebrating her was amazing. But listening to the keynote speaker and her lived experience, and how her journey brought her into this space, and how she has become an advocate and a champion for spreading the word with OCD, but also shared, you know, her early journey where she was like, oh, I'm going to tell everyone about OCD, but then later found that she didn't. And, you know, it took her some time to be able to get more comfortable with the language, more comfortable with herself, more comfortable with her treatment, to be able to stand in front of us this past weekend and give such an amazing and entertaining speech, because she definitely was funny. I know I got some good laughs out of it. So that was a great experience. And again, just to be around folks sharing their lived experiences and giving us anecdotes that were helpful for them. Like yourself, it just gets your wheels turning. It starts to spark that intellect as to how I can apply these things with the folks that I see. So that was just, you know, so amazing. And then of course the party is the icing on the cake. The food was great. Being from Chicago, I love that they, you know, did a nice little taste of Chicago with the Chicago style hot dog station and the deep dish pizza and the taco bar and the pasta. So they incorporated a lot for everybody and made it a very multicultural experience, which I appreciate, because I think that that is a lens that we should continue to look through. As you named earlier with OCD, there's not a lot of research in a lot of spaces, the LGBTQ space as well as the African American space, and it is definitely under research. So to continue to see the efforts that are being placed in those conversations, as well as hopefully in the research to back, you know, the tools that we're using, is definitely something that was talked about and gave much encouragement to myself.
Yeah, I remember when I was writing my thesis, it was really only Dr. Monica T. Williams was the only one really doing any research on just the impacts of marginalized groups and OCD. And I remember we had to write a certain amount because my program really wanted to hone in on that. And I'm like, there's no research. So I had to like use, they wanted us to have like 5 different research labs. And I'm like, there's only one. So it's good to see that there's more labs. Before I let you go, Lovely. Okay. I need to ask you this because I have a good friend that was there that knows Chicago. Y'all eat your hot dogs way different. So I had a hot dog. I was telling Sarah before I went to the Katy Perry concert last night, and I had a hot dog and I ate it how we do in LA. But there's like, you got to explain it. So no ketchup, apparently. I was like, where's the ketchup? And the worker looked at me like I was like doing a cardinal sin. And then there's like celery salt. There's like all this stuff. So tell them how to do like a proper Chicago hot dog.
So a proper Chicago hot dog, you got to have your sesame seed bun, right? And I love the celery salt. That's the main ingredient for me. You have mustard, no ketchup. You do onions, you do relish, you do a nice sliced dill or kosher pickle with the celery salt, and it's fantastic.
I did do it a proper way. I could get behind it. I love yellow mustard. Like that's my thing. I put on everything. Without the ketchup, hurt a little bit, but you know what?
You have the tomato to give you.
yeah. And the deep dish is incredible. There's barely any places that do deep dish out here. So I was so excited to eat deep dish pizza. So if you come to the conference, you get to eat. I don't know. It's going to be in Seattle next year, and I have family. I don't know what Seattle's known for. I guess coffee. We'll have coffee at night, but
Seattle teriyaki. Seattle teriyaki is where it's at.
Oh, what is that?
It's a very specific type of teriyaki. It's certainly not the healthiest, but it's different from any teriyaki I've had anywhere else in California and Ohio. It's just different.
Yeah.
Ooh, I look forward to that.
Yes, next year at the conference. But I will say the Chicago food was good. How for you, Sarah? Emily was our keynote. If you got to see that or go to the party, or what was that like?
I didn't go, but it's because I ran into a really good friend from grad school that I didn't know was attending the conference. And we went to dinner and got carried away talking. And I was like, well, shoot. So I didn't make it. But I was also really happy to be able to catch up with this really good friend from grad school.
You know what the cool thing though is like it does feel like that. There's so many people that you get to see, so many people you get to run into. What I wanted to ask before we jump into questions that people are putting in the chat, what was it like? I think for me, one thing I always walk away is hope. Liz McInville, who hosts once a month with me, was actually speaking at the first conference I went to, and she's around my age, and she was talking just about her experience about getting better. And I remember walking away from the conference, even though we had to leave early, it wasn't a bust. I remember the other thing is there was also somebody who was younger, I think she around my age at the time, like 19 or something. And she was talking about how she started a support group at our high school. And I think the big thing I walked away with was hope. Like there are people out on the front lines researching it. There's medications being developed. There's people treating it. There's people getting better. Before we move into questions, can you talk about the hope piece? Like, did you get that at the conference, and where did you see it? Where did you feel it? And letting the audience know just about people getting better.
1000%. I think between the research, the clinician sessions, the support groups, the major takeaway for me was the energy and passion that folks have for treating OCD. I know I walked away with even more of a renewed kind of vigor for treating OCD and wanting to really take on more cases. But also just people are continuing to research. We're continuing to evolve our information on this topic. We're trying to expand treatment services. People are building programs. So there's still very much growth in this field and in this area, this very specific area. And I find that incredibly hopeful. So that was amazing to see.
Yeah. And for you, Lovely?
I agree with everything Sarah said. Well said. I left walking away with those same sentiments. I was very hopeful, encouraged, wanted to open up my calendar and take more patients. Definitely seeing the other clinicians have the enthusiasm that they have, the passion that they have, the information that we're all, sharing and exchanging, and just, the real life investment that they have for, treating this disorder, and other co-occurring disorders that come along with this at times, depression and so forth. It was just very much so, enlightening, and spoke to my values of why I'm here and why I show up every single day doing this work. So it was just affirming. This is what I continue to go back to.
Yeah, no, I agree with both of you. I mean, one of the cool things is people with lived experience speak, and people are talking about getting better. And I think, my mom went to a conference before I was able to go. I just was the year she went was when we were looking for treatment, and I was in a horrible place. And I remember her coming back and not talking a lot about it. And I asked her why, and she was like, there just wasn't a lot of hopeful stories. And this was many years ago. But that was something my mom came to the conference with me, and we were reflecting on it. And she's just like, wow, there are so many people getting better. There's so much hope. There's people sharing their stories. There's case studies about people getting better. There's just like, it's full circle. She's like, some of the people that I saw even on the first day walking around kind of head down, sort of anxious, were on that dance floor on Saturday night, like dancing and things like that. So it's just cool. And I hope everybody watching knows, we had 2,200 people in a hotel with 1,000 watching. And there were so many people getting better. So I hope everybody watching doesn't have that feeling like they can't get better. You absolutely can. We're going to jump in questions, and let's start with Rebounce on YouTube. It's Emilio. It's at 12:07. It's broken up in 3 parts, so I'm going to sum it up together. But Rebounce says, I'm really sad. My mom went to the grocery store. She was kind of late. My brain came up with so many negative scenarios, like what if she's cheating on my dad? So when she came home, I was trying to indirectly ask why she was late to get reassurance. So can both of you speak a little bit about why our brain, not the science behind it, but just like why people with OCD, that's Rebound seems to be sort of beating themselves up a little bit. So maybe talking about 2 points, and you could jump into either one, is just normalizing intrusive thoughts, because this is what OCD does, right? Creates up stories. And then second, that need for self-compassion, because I can see in the comments Rebounce is really beating themselves up, and why self-compassion is so important when we have mental health conditions. And either of you could take either part.
I can start and at least test to a little bit of that, but the whole thing about OCD is that we have these thoughts that are distressing, and they are painful to have, and they're scary to have, and we don't want to have the intrusive, obsessive thoughts. And so to layer judgment and guilt on top of that is a whole other layer of distress that just makes it so much more intense. And it's sometimes you'll hear it called like the double arrow, where you're first having the thought, which makes you feel like crap, but then you also have a judgment about the thought, which makes you feel like crap. And so that's the importance of the self-compassion, is knowing that this is what the disorder does. This is what OCD does. It is designed to make you feel scared so that you do the compulsion. And so in order to really be able to confront that fear, we have to take that judgment away. And it's hard. I'm not saying it's easy, but that's the importance of the treatment and learning how to take that judgment away so that you can face it head on. You can understand the nature of the beast and be able to do ERP effectively.
Well said.
Well said. I would just add to that, continuing to recognize that our thoughts and our feelings are not facts. And that self-compassion piece, as Chris and Sarah named, is super, super helpful for us to be able to give ourselves what we tend to give others, which we often forget to give ourselves. We'll pull out those boxing gloves and beat up on ourselves for having that thought or for having that feeling. And as Sarah named, that is what OCD does. That is its job, is to cause this chaos in your brain and in your nervous system, to create this anxiousness so that you feel compelled to do the ritual, and allowing yourself to know that, again, these thoughts and these feelings are not facts. There's no evidence behind that. And yes, these things are scary, normalizing it, as Chris said, so that you know that it's not something unnormal for us to have these thoughts. Folks who don't have OCD will have that thought. I would have a thought. I just had that the other day, honestly, when I wasn't feeling well, and my mom went to go get some medication for me, and she was gone for a very long time. And I'm thinking to myself, what happened? Is she okay? It shouldn't have took her this long to go to the store. But then I had to be like, she's fine. Nothing happened. She's going to call me when she's on her way back and everything's okay. And it was. So allowing ourselves to try to slow it down, have a little bit of mindfulness and self-compassion with our thoughts and our feelings that are showing up.
Well said, both of you. The only thing I would add too is I was taught on looking for patterns. That was what I want you to try. I think it was rebound. Yeah, rebounds. What I would also want you to try rebounds is start to look at patterns. Do you notice that you'll have these like thoughts, kind of like what Lovely was saying? Do she recognized her mom's going to be safe, everything's fine. Start to notice those patterns. If every day your brain is coming up with these worst case scenarios, yet they never come to fruition. I always use this analogy. I'm like, if your friend called you and said they had tickets to like the best concert you've ever wanted to go to, and they're like, I'll pick you up at 7, and then they never show up and are like, make up an excuse, but then call you next weekend and be like, don't worry, I have these tickets, and then don't show up. How many times would they have to totally like flake out until you're finally like, hey, I'm not going to like open up my plans anymore for this person. They just never come through. Look at those patterns in OCD. Do you notice how every single time those worst case scenarios come up, they never come to fruition? Would you trust that? Maybe starting to recognize that it's not trustworthy, like both of the clinicians are saying on the panel. And additionally, I always tell clients, practice the delay method. You don't have to ask your mom that question right away. See if you can go a little bit longer, because once our angst goes down, our clarity goes up, and then we can say like, hey, my brain created something crazy again. I don't need to listen to it. It came up with this. I always tell people like my brain, having OCD, my brain comes up with a cast, a crew. It has a script, and it comes up with this whole vivid thing, and then it's never come to fruition yet. This is a good question for Trevor B on YouTube. Do you ever experience clients that with OCD experiencing major recovery stress with ERP treatment, but then relapsing after a couple of years and having a difficult time recovering again? So can you both talk a little bit about lapses or relapses or people going through hard times, and what are some strategies or things to remember as they kind of get back into treatment again?
Definitely. I just had a client return for reasons of having a relapse. And that's something that I talk about in my treatment initially when we began and throughout, as reminders that we have our back steps, as I like to call them. A lot of these practices and rituals that folks have been doing have been with them for a very long time. They've served some type of functioning for them, and they can be habitual. They can show up in spaces where we don't want them to. And I use the example of if I have the same routine every single day where I get up, brush my teeth, go to work, come home. But today I want to go to the grocery store. But before I know it, I'm at home already, and I'm already in my pajamas because that's my habitual routine. I'm like, darn it, I didn't go to the store. So we want to be able to, again, use that self-compassion with ourselves, recognizing that the back step does not take away from all of your accomplishments, all of your hard work, all of the tools that you learn. We just sometimes need to come in for a refresher. We need to come in for a grounding to get ourselves back to a good baseline so that we can remember some of these tools that we've learned and get out of some of those habitual practices that try to resurface.
Yeah, I like that a lot.
Absolutely. Everything that Lovely said. And I would also add that we know that the data shows that if you are diagnosed younger, like in your childhood or teenage years, there tends to be a more kind of cyclical nature of OCD. And we know that symptoms can come up after a major life stressor, like a transition to college, to a new job, a big move. After a physical illness too, we can see that ramp up sometimes. And so we know that OCD symptoms ramp up at particular times. And we also see that if you're diagnosed earlier, we are more likely to see those kind of spikes throughout the lifetime. Again, that is not to say that it's not treatable each time, but treatment might look a little bit different. Maybe you've kind of gained everything that you can with your last therapist, and maybe you want to try someone new. We always want to stick with kind of the evidence-based treatments, but maybe if you're not vibing with your last therapist anymore, you want to try someone new who does ERP or ICBT if that's your treatment of choice. And so knowing that you will continue to grow and evolve as a human, and your OCD symptoms might too, and just knowing that and normalizing that, I think is really important as we just kind of continue to navigate this disorder throughout the lifetime.
And what I'd say too, Trevor, is like the good news is if you had really good success with ERP and OCD treatment, you have it, right? It just something shifted, and like what was discussed, sometimes we get back into old habits, like Lovely was saying, or we have a life stressor, like Sarah was saying. What I always tell people is what worked? What worked the first time? Really try to recreate that. And if something feels very different this time, you know, letting us know as clinicians. I know that sometimes I've seen clients that did really, really well in treatment, either with myself or someone else. And then maybe they have a loss in the family, or they're going through trauma or PTSD as well, and that's not being addressed. Sometimes it's a higher level of care. So I'd really connect with someone and talk and map out what worked. I don't know if you both do that. I always ask clients who have been in treatment before, like, what works? Because I want to pull that. And then was there something you absolutely hated? Because I don't want to keep doing it if it didn't work for you. So the next question comes from Suprap on YouTube, and they say, how does the treatment help with reducing severe intrusive thoughts and a change in emotion? So I like this question because I think we all know that OCD really impacts our thoughts. We get these thoughts that are just unpleasant. We don't really like them. But it also causes like a huge change in emotion. Somebody's triggered and suddenly they're dysregulated and they're feeling like, really, you were talking about it earlier, Lovely, just like overall like impact in the body. So can you walk through how treatment, when you're working with a client, what are you noticing in your clients over time when it comes to the relationship with the thoughts and their emotions through treatment?
So I always like to talk with my clients at the start about how we know that CBT for OCD does actually change your brain circuitry. We know that it has an actual effect on your brain through learning. And so what ERP is all about, for example, is changing your learning. So not only are we changing our response to the intrusive thoughts, over time, those intrusive thoughts actually do start to decrease because we have changed our reaction. So it's this really cool interplay between learning different skills and confronting those intrusive thoughts that makes them both, one, less intense to experience, but two, they do decrease in frequency. And when that happens, people aren't as bothered by them. People are able to have those kind of brief intrusive thoughts, recognize what it is, and go, okay, moving on with my day, rather than spending the next several hours kind of ruminating on that thought or doing compulsions over and over. So starting out by telling my clients that, but also saying, you're not going to believe me until it starts happening, and then doing the ERP and watching it start to happen over time. I usually get feedback about how effective that was and how they didn't believe me at first. But then over time, they started to see, wow, I had that same intrusive thought and it didn't really bother me. I was able to move on with my day. And that's always really rewarding to see as a clinician.
Yeah.
Agreed. Well said, for sure. In addition to that, I would say recognizing again the normalization of the thought and how folks can internalize that. And when you're learning that principles through CBT and doing the exposures with ERP, as Sarah named, we start to take away a lot of the weight of these thoughts, and the internalizations don't become as significant to where you believe the thought to be true to your self-identity or something that you will actually do. I use the example in my therapy of, we all have negative thoughts or nasty thoughts that we don't want to have. When I first had my son, thinking about holding him out the window, I would never do that, but that's a thought that would come up, something that is just completely different from who I am or what I would actually do. We don't have full capacity of our brain to control every single thought or emotion that shows up. What we do have is the ability to be able to manage them and normalize them. And one of the harder pieces is the management piece, because it can feel very, very uncomfortable to sit with some of these emotions, to sit with a lot of these thoughts. And once we allow ourselves, again, that normalization piece to recognizing that these thoughts are not who I am, then it is, as Sarah named, a beautiful thing to witness the treatment evolve in the way in which a person becomes very comfortable with all the thoughts that they have and not ruminate on them in a way that causes them continued distress.
Yeah, and both of you said everything. The only thing I would add is, around the emotions piece is we're learning in treatment to confront and to address things versus to push them away. And I think in life, if you take it outside of OCD and you think about interactions with people or when you have something stressful coming up, the more we avoid, like I used to be a great avoider when I'd have a test or something when I was stressful when I was a kid, I just pretend it didn't exist. And then it would come up and I was completely not prepared and I was, added so much, angst to it. But when I started to learn through ERP and CBT, but additionally just outside of treatment, now anytime I just address things head on, you kind of build this confidence in yourself, like I can handle that. And I think that's one of the great things. I see it more in kids because adults rarely like in session are like, wow, I'm strong, but like kids get so excited. I have mints in my office because it's like the only thing that I won't eat. Because when I used to have chocolate in the office, people would be like, oh, you're out of chocolate. Your clients ate it. I'm like, yeah, my clients ate it. Not me, of course. But mints, nobody wants to eat like 48 mints, right? But I had a client who, even though they're individually wrapped, he didn't want to eat them because he was worried, but he really wanted them because he liked mints and eventually started getting comfortable and eating them in session. He was real young, single digit age. And I remember him just being like, I can eat them now. I'm so proud of myself. And it's like, that's what's so cool about treatment is you start to learn a confidence in self for sure. One thing I spoke about at the conference is addressed at 1227 from Sadhu on YouTube about insomnia with OCD. So I'll jump into this one quickly, and then if you wanted to add anything. So I was trained in CBTI. It stands for Cognitive Behavioral Therapy for Insomnia. One thing that I would say is, when it's around a medication piece, you definitely want to involve the psychiatrist as well as maybe a doctor perhaps. But in research, typically only about 25% of people have medical induced insomnia, whereas 75% of people, it can be sleep habits, it could be anxious, it could be anxiety. I know it's difficult because, with our great insurance in this country, but if you can get a sleep study, that will help give you some insight on what may be causing that. I don't know if you were able to access the talks at the conference, but one of the talks I did was about sleep for people with OCD. And a lot of it, what I see my clients doing is staying up late, either because of physical rituals or to avoid mental thoughts. They're kind of distracting themselves. So they'll pass out in bed and not sit in bed with their thoughts. So really looking up CBTI strategies or working with the clinicians that you could learn how to better have some sleep hygiene to only use your bed for sleep. But if you really did get it through medication, I would definitely talk to the prescriber. But is that something that you see in your clients sometimes, just like a struggle with sleep or getting good sleep with OCD and anxiety and depression?
I would say yes. I think it tends to, in my patients, be anxiety driven, laying in bed and just thinking and thinking and thinking, or it's directly related to OCD. I had a patient once who didn't want to fall asleep because her OCD was telling her that something bad would happen if she fell asleep. So often I see it in terms of either compulsions are keeping folks up really late, or intrusive thoughts are telling them they can't go to sleep. So that's the context in which I tend to see it. I have not seen a ton of medication related insomnia, but I do always, like you said, encourage folks to just go to their provider.
Yeah.
Agreed. Same here. I don't see a lot of medical results from that. Definitely, excuse me, as yourself and Sarah named, that with is either the anxiety that's keeping them up with ruminating, or it is a life stressor, something big coming up where I had a client who was studying for the bar. So of course that anxiety and stress of thinking about the exam and wanting to do well and wanting to pass and having those targeted thoughts around that specific thing kept them up more so at night. So that was more so the OCD coupled with the anxiety for the test versus any medication. But again, of course, always consult with your medical provider and investigate those symptoms that are presenting.
Well said. I'm going to get to one last question, then I'm going to give both of you an opportunity to kind of to final thoughts. Real quick, Miguel, you asked a question at 1229 about TMS research. What I'm going to do is every second Wednesday of the month, we bring on someone that specializes in both medication, but additionally psychopharmacological interventions like TMS, DBS, and stuff. So I put your question at the top of that list. I have a lot of questions for the next psychiatrist. So please join us every week, Miguel, of course, but at least the second Wednesday. of the month. I believe we already passed it this month, so it'd be next month. But there was definitely TMS research and boosts, and I'd rather them talk about it because I am definitely not. That is not in my wheelhouse. But I think this is a lovely question to end with. It's from LinkedIn, and it comes from Jesslyn at 12:30. She says, "Good morning or afternoon. I'm one of the grassroots IOCDF advocates, and I'd love to hear your advice on building advocacy experience and outreach." So just being at the conference and seeing your clients, what do you think is missing with advocacy? What do you think something that you hear either at the conference or in your own clients, or just like thinking about mental health in general? Our IOCDF grassroots advocates are usually people with OCD or somebody they love has OCD, and they're really trying to build community and outreach. Like, what are some things that you think are missing that maybe Jesslyn could write down and try in her own community?
I think one thing for me is working in a big hospital system, trying to find reasonably priced services can be difficult. A lot of providers do not take Medicaid, for example. And so one of my personal missions is to try and kind of diminish cost-related barriers to care. I also do appreciate that there's more efforts to how OCD is represented in pop culture and the media. And so whenever I hear somebody talking about OCD out in the world, I try to make sure that they're saying correct and informed things. And if there's something that's harmful, I might gently correct them. But I do think that there are efforts being made both in the larger world and in pop culture and media, and then within different health systems to try and make care equitable and accessible for all. So I don't know that that's directly tied to what we can all do in our community, but whenever you see those opportunities, grabbing them.
Yeah.
Agreed. In addition to that, one of my takeaways was recognizing that there is a large gap in the BIPOC community. As you named earlier, Chris, just in marginalized communities in general, with it not being that much advocacy and outreach in those particular communities to get awareness about treatment for OCD, as well as a lot of Black and Brown folks stating that they couldn't find therapists that looked like them to be able to feel safe and have that psychological safety of going into treatment and being able to divulge all of, them true selves to what would be a stranger. So for me, just networking with my colleagues and trying to make ourselves more present with social media, as Sarah named, delving into some of these avenues that I have not before. I've never had a Facebook page. I currently do not have a Facebook page. So getting a Facebook page and just being a part of platforms and being a champion and advocate for OCD as a therapist and connecting with, like I said, my fellow clinicians who do practice and who do specialize in OCD and other chronic related disorders, so that the community does know that there are therapists and clinicians out here that look like them, that do specialize in these treatments and do have hopefully some affordable measures that they can exercise to be able to get the treatment that they need and what they deserve.
And I'll just thank you so much. And I'll just say really quick, Jesslyn, as an advocate, connect with your local affiliate. A lot of times they're boots on the ground and they can help and support things. Also, the IOCDF puts out kind of call to actions to the IOCDF advocates, grassroots as well. So really joining that, and then find something in your community. It could be talking to your school. It could be connecting with others. And sometimes people forget that advocacy could be literally just sometimes talking to other people about what OCD is. But we're at time. I'm going to make quick announcements, and then I'm going to give Sarah and Lovely a final kind of sentence or two to wrap us. But for everybody that went to the conference, thank you. To the ones that came up and said hi to me, thank you. Thank you. I love doing these live streams, and I'm so happy that you find them helpful and came up to me. That was an honor. But thank you for joining us every Wednesday. We'll be back next Wednesday at 12 Eastern. My takeaway from the conference is I got the cutest little conference bear that has like the IOCDF, and it says, life can be rough, and I like silly puns, so I got that. But it was just so cool to see so many people in the same room advocating for hope and change. So if you can make it next year in Seattle, please come by. Sarah, what's kind of your final takeaway, either something from the conference or just anything you'd like to leave our audience with?
I am just so grateful for IOCDF and the community that has been built around OCD and related disorders. Whether you are someone with lived experience, a clinician, a researcher, IOCDF has something for everyone. And if you can't attend the conference, there are so many other avenues for involvement or learning or support. And so for folks who can't attend the conference, look for other ways to get involved and get support, because there are so many. And I know there's plenty of people within IOCDF who can help you get connected. So I'm just very grateful.
Well said. And then finally for you, Lovely, what would you like to leave everybody with?
Agree and double down on what Sarah said. Also, going back to what you said earlier, Chris, if the clinician that you're working with may not be the clinician for you, please do not allow that to be the end of your journey. Please continue to reach out, look for someone who is a good fit, and find that good treatment and relationship that you need to be able to continue on with your journey.
Thanks, Lovely. Well, thank you to Sarah. Thank you to Lovely. It was so exciting to hear people's first experiences. I remember when we were talking about this live stream, we wanted to find some clinicians who it was their first time. It was so cool to hear that. If you can't make it to the conference in Seattle next year, remember there'll be a hybrid option so you can enjoy it from the comfort of your home. Big special thank you to both Sarah and Lovely for being my guests this week. We hope you come back next Wednesday at 12 Eastern. And remember, IOCDF.org for all your OCD and related disorder needs. Have a wonderful rest of your day. And remember, OCD is a liar. And if we didn't get to your question, I'm going to put it on a sheet. Make sure to get to them next week. I'll see you then. Take care, everyone. Have a great rest of your day. Bye, Lovely.
Bye.
Go eat a Chicago hot dog.
Yes.
I love yellow mustard, so it's good for me. So I'll just keep putting yellow mustard on it.